Hello everyone, my name is Selena Tobias Grasso. I'm an audiologist and senior training manager at the Education and Training Department in MED-EL headquarters in Innsbruck. This presentation is an overview of the auditory brainstem implant, or ABI. So far in this program, you've learned about cochlear implants, electric acoustic stimulation, middle ear implants, the vibrant sound bridge, and the bone conduction implant, the bone bridge. And those devices address hearing losses, as you can see in this image, that arise from pathologies of the outer, middle, or inner ear, the cochlea, or cochlear hearing losses. Now, what about hearing losses that are due to problems with the auditory nerve or retrocochlear hearing losses? That's where the auditory brainstem implant comes in. For the next 20 minutes, I'm going to give you an overview of the device. So we're going to talk about the implant and the audio processor. Then I'm going to talk about candidacy criteria for the ABI. We're going to look into who the potential candidates are for an ABI and also the contraindications for ABI. Then I'd like to briefly discuss surgery and fitting of the ABI, especially within the context of the differences between cochlear implantation and auditory brainstem implantation surgery and fitting. And then I'll end with some take-home messages. Let's start with an overview of the device. What is an auditory brainstem implant? So the ABI is a device that bypasses the inner ear and auditory nerve and directly stimulates the cochlear nucleus of the brainstem. Whereas a cochlear implant is inserted into the cochlea, as you can see here. An ABI electrode is placed on the brainstem, so you can see that it bypasses the inner ear and auditory nerve. What are the parts of the device? You have an internal implant and an external audio processor. For this presentation, I'm going to be focused on the MED-EL Synchrony ABI system. So the Synchrony ABI implant that you can see here, and also the Sonnet and Rondo audio processors. Although the ABI is also available in a concerto implant, we're going to be talking about the Synchrony here. Now, before I go into detail about the implant, I have a question for you. The question is, what is the main difference between a cochlear implant and an auditory brainstem implant? And I'll give you a few seconds to think about this, and then I'll give you the answer. The answer is the main difference between an ABI and a CI lies in the design of the electrode array. You can see in this image a picture of a cochlear implant electrode array where you have the different contacts, electrode contacts. So you have 24 contacts in pairs. So the design of a cochlear implant is really specifically made for the cochlea, for the tonotopic map of the cochlea. While an ABI electrode array is designed as a surface electrode placed on the cochlear nucleus. So the cochlea is tonotopically arranged where you have high frequencies stimulated at the base of the cochlea and low frequencies stimulated at the apex. So the electrode design of a cochlear implant is really made for insertion into the cochlea, while an ABI electrode array, where the cochlear nucleus tonotopic map is more parallel and oblique, a surface electrode design where you have the electrodes on a silicone paddle and you have a polyester mesh is the ideal design for placement on a cochlear nucleus. So here you have more details about the ABI electrode array. As I mentioned, you have 12 active electrodes placed on the paddle with one reference electrode in the middle. The polyester mesh is 5.5 millimeters long and 3.0 millimeters wide. And at the basal end of the electrode array, the diameter is 1.3 millimeters. Now let's talk about the audio processor. The Sonnet audio processor is our latest technology at MED-EL. And the beauty of the Sonnet is that we are backwards compatible, so patients who were implanted with previous generations of the ABI can benefit from the latest audio processor technology. The Sonnet is a behind-the-ear audio processor. It has a modular design, integrated telecoil, dual microphone technology. It's water resistant, splash proof with a rating of IP54, so ideal for humid areas, and is also tamper proof. Sonnet also features wireless connectivity and automatic sound management. ABI users can also benefit from the Rondo single unit processor, where you have just one compact and fully integrated unit with no cables. And with the waterware, the Rondo is waterproof with a rating of IP68. So that covers the overview of the device. Now let's go into candidacy criteria for the ABI. Who can benefit from an ABI? Generally, patients who cannot benefit from cochlear implantation due to non-functioning auditory nerves are the ideal candidates for an auditory brainstem implant. Now, the non-functioning auditory nerve can be due to a number of reasons. It could be because of neurofibromatosis type 2 or tumors on the auditory nerve, or could be because of cochlear aplasia or cochlear hypoplasia, which we'll be talking about in the next slides. So these are the ABI indications. The patient has to be 15 years of age or older, although we recently received approval for expanded indications in CE marked countries, so in European countries mostly. Typically, the age should be 15 years or older, but with the expanded candidacy criteria, we can implant in patients who are 12 months or older. Now, this candidacy criteria differs in region to region, so if you have any questions about this, please contact your MED-EL, local MED-EL representative directly. Patients should also have a diagnosis of neurofibromatosis type 2 or NF2. Both cochlear nerves should be non-functional or are anticipated to be rendered non-functional because of tumor removal surgery. And typically, when you implant an ABI, it happens concurrently with the removal of a tumor in cases of neurofibromatosis type 2. Now, I talked about expanding indications in CE marked countries. So now we've received approval for implanting the ABI in patients who are 12 months of age and older. Not only can we implant in patients with NF2, but we can also implant in non-NF2 tumor patients and patients who have auditory nerve aplasia or hypoplasia. Auditory nerve aplasia means the absence of an auditory nerve, and hypoplasia means the underdevelopment of the auditory nerve. Patients who have head trauma can also benefit now from an ABI. If the head trauma caused fracture that affected the auditory nerve, then patients who might not have been good candidates for a cochlear implant can now use an auditory brainstem implant. And also patients who have severe cochlear ossification. This means that an electrode array cannot be inserted into the cochlea because the cochlea is ossified, and so an ABI would be a good choice for these patients. What are the contraindications for an ABI? First, of course, if the patient is intolerant to the materials used in the implant, they wouldn't be a good candidate. If a patient has unstable psychological status or unrealistic expectations, especially for a device like an auditory brainstem implant, which is implanted in very complicated cases, the patient has to have very realistic expectations. Another contraindication is anatomical abnormalities or surgical complications preventing placement of the ABI electrode. If there's deafness due to central damage of the upper auditory pathway, that's also a contraindication. If during tumor removal surgery, there is possible preservation of the cochlear nerve, then you wouldn't need an auditory brainstem implant. The patient might go for a cochlear implant in this case. And if there's a critical medical situation of the candidate due to multiple tumors or hydrocephalus or other complications or situations, then the patient would be contraindicated for receiving an ABI. So that covers our candidacy criteria. Now let's talk about surgery. I want to start with the differences between CI and ABI surgery. Now, ABI surgery is brain surgery, whereas cochlear implantation is ear surgery or otologic surgery. Auditory brainstem implantation, since you place the electrode on the brainstem, is considered as neurosurgery or brain surgery. Also, with a CI, the electrode is inserted into the cochlea. For an ABI, the electrode is placed on the cochlear nucleus of the brainstem. In cochlear implant surgery, you would typically intraoperatively obtain IFT measurements or impedance field telemetry measurements. In ABI surgery, in addition to obtaining IFT measurements, it's also very important to do electrically evoked auditory brainstem response measurements, or EABR. And the EABR is important to be able to confirm correct placement of the ABI electrode. Now, what are some fitting considerations when programming an ABI user? Similar to programming a cochlear implant user, when you program an ABI user, you also need to obtain thresholds and MCLs, or most comfortable loudness levels, and these are used to form a map or a program for that patient. Now, there are a lot of differences as well between programming a CI user and an ABI user. One of the main differences is, since the electrode is placed on the cochlear nucleus, the electrode could be stimulating nerve fibers that are not part of the central auditory pathway. And therefore, the patient could suffer from non-auditory sensations like headaches or muscle sensations. And so the clinician would need to deactivate the electrodes that are contributing to the non-auditory stimulations or sensations. Another difference between programming a CI user and an ABI user has to do with tonotopy, or the tonotopic map, and the differences between tonotopy in a cochlea and a cochlear nucleus. So you can see here, this is in the image the electrode array placed into the cochlea, and you learned from previous lectures that the cochlear tonotopic map has been widely studied, and is very clear that when you place an electrode fully inserted into the cochlea, this electrode would typically stimulate lower frequencies, while your basal electrodes would typically stimulate higher frequencies. Now, what is the equivalent for a cochlear nucleus? Like I mentioned earlier, tonotopy in the cochlear nucleus runs more parallel and obliquely. Specifically, you can see in this image here from a study by Candler that was published in Nature Neuroscience, you can see that the blue colors or the darker colors represent higher frequencies, while the more warmer colors or the oranges are representative of lower frequencies. So for the cochlea, like we mentioned, higher frequencies are at the base and lower frequencies are at the apex. But what is the equivalent for the cochlear nucleus? Typically for cochlear nucleus, lower frequencies are represented laterally, while higher frequencies are represented medially on the cochlear nucleus. So therefore, it's very important for the clinician to really obtain patient-specific tonotopic map. So you need to test each electrode and get feedback from the patient whether or not they're hearing higher frequencies or lower frequencies to be able to obtain a specific tonotopic map for this patient. What about about ABI performance? Usually you would anticipate that an ABI user performs poorer than a multi-channel cochlear implant user, but we have had some positive performance in ABI users who would not necessarily benefit from a cochlear implant. In a study by Choi in 2011 where they looked at non-NF2 tumor patients who were implanted with an ABI, so these patients had a narrow internal auditory canal. There were 8 patients, and you could see that the categories of auditory performance scores or CAP scores in these patients, the mean CAP was 3.4, and there was improvement in CAP scores over time in the patients. Professor Coletti in Italy has done a lot of ABI implants in children, and in a study published by Coletti in 2014 where they looked at 64 children who were implanted with an ABI and followed them for 12 years, all of the children in that study showed improvement in auditory perception with the implant. And 11% were even able to achieve the highest score on the CAP test and were able to converse on the telephone within 3 years after implantation. 31.3% achieved open set speech recognition and a score of CAP score of 5 or higher. And 62% achieved a CAP score of 5 or greater with the ABI. So in that study, Coletti found that performance was, or best outcomes were achieved when the patients were implanted with pathologies of cochlear ossification, head trauma, eighth nerve aplasia, and cochlear malformation. Those were the patients that reached best outcomes compared to the NF2 tumor patients who were implanted. So that brings us to the end of the presentation. And I'd like to now give you some key messages that I'd like for you to take away from this lecture. As I mentioned, this is just meant to be an overview of the ABI to give you an idea about candidacy criteria and general considerations for fitting and surgery. But what do I want you to take away from this lecture? First of all, the ABI is an option for patients who cannot be implanted with CIs. And with the Synchrony ABI, with patients who are ABI users, because of their pathologies, you would typically anticipate they would need an MRI after surgery. So with a Synchrony ABI, you can perform MRIs without magnet removal. We should also remember that candidacy is now expanding for the ABI. We're implanting patients who are non-NF2 tumor patients. Patients who have cochlear aplasia and hypoplasia can benefit from an ABI now. And lastly, when fitting ABI users, it's very important to find a patient-specific tonotopic map, like I mentioned earlier, because of the differences between cochlear tonotopy and cochlear nucleus tonotopy. So thank you very much for your attention, and I hope that you benefited from this presentation.